I think. And we got a lot of familiar faces today, so this will be fun. For those that don't know, we got Dan and Tim. They're both UCSF ties. This will be great. And then we got one more after this. That'll be good. We'll keep this fresh. No announcements today. Thanks for those that went to the mental health hackathon. There were 500? 600 people for 24 hours hacking away. It was super successful. It's pretty interesting. So it was a really cool event. One of the main people that did it. So props to him and everybody that went. So it was awesome. We'll keep this nice and light like usual. We'll start off with Dan and go to Tim after that. Eat all the food. Sorry for the folks online. They can't eat the food. It'll be good. And we'll kind of go from there.
They're working.
They're working. Go ahead. Please.
Cool. So thanks for having me. It's great to be here. I spent a couple years as a postdoc here and was in this room quite often. I knew exactly where to go. So today I'm going to be talking about a mobile app that we've been developing that is designed to address social functioning in people with schizophrenia. My interest is in mobile technologies and helping folks with serious mental illness, particularly in their recovery-oriented goals and how we implement evidence-based practice using technology as our kind of framework. Let's see here. So the framework that we start with in terms of understanding social impairment in severe mental illness is really through the idea that there are a couple of key problem areas. One is in skill deficits, and these are well-researched, also well-treated for the most part in people with schizophrenia. And what those look like are often difficulties in initiating conversations, monitoring what's going on with others and responding to others in their immediate environment, and displaying appropriate verbal and nonverbal behaviors. So this might be paralinguistic features as well as just turn-taking and interruptions, things like that in social situations. What causes that? Well, myriad factors, but neurocognition, broadly speaking, social cognition, maybe more specifically, and psychological factors, things like defeatist attitudes, where people have low self-beliefs around their ability to engage with others and do so appropriately. So the other piece that we focus on is really social motivation. And this is something that I've really dedicated my work towards in understanding more basic science of this, but also how it applies to interventions. People with schizophrenia report that they really want relationships, not surprisingly. But the problem seems to lie in exerting effort in the service of connecting with other people. So it's I want to have relationships, I want to have better friendships, I want to have romantic relationships, I'm not really sure how to do it, or I have challenges and barriers in seeking out that contact. What contributes to that? Well, negative symptoms, or the absence of psychological or neurobiological qualities that we all exhibit kind of organically, naturally. In this case, primarily avolition or low motivation, broadly speaking, but also these psychological factors that I talked about before, like low expectations for success, and that might limit people's with schizophrenia, their engagement in social connection. So I want to have relationships, I struggle with moving forward to attain those relationships. And this leads to some of the key problems in schizophrenia, which are social isolation and loneliness. And these problems lead to poorer outcomes among people with schizophrenia in terms of hospitalizations and even occupational functioning outcomes. So they're important to address. The model that I like to use to understand what's breaking down in terms of, say, the connection between a motivated state and actual social connection is the temporal experience of pleasure model. And this model has been used to kind of understand motivation, broadly speaking, in schizophrenia and other conditions like depression. But when it comes to social motivation and social dynamics, we think that there are similar processes that are working here. From a normative standpoint, when we are thinking about interacting with others, that's what I would term a social goal state. Interacting with others, building relationships, broadly speaking, relationships that might be intimate relationships or just surface level relationships, but that's something that's activated kind of from a cognitive standpoint, psychological standpoint, which leads to this idea of social wanting. I want to have a connection with somebody, and then the effort and the drive, the actual behavior, the observable behavior flows out of that. That's how it should work. And we think what activates this social goal state is really a kind of an affective, motivational, you could think of as a neurobiological, but also kind of a memory foundation cognitive state. And what happens is the positive prior social experience that I can drum up in my memory links with that social goal state through this kind of cognitive integration process, very automatically, right? So I'm thinking about having coffee with somebody, I remember that being pleasant, I feel good about that, that drives my goal state to then seek out the relationship. And just like in motivation generally, we think that what might be happening here in schizophrenia is that integration is not working properly. Why? I'm not entirely sure. Could be basic cognitive processes, could be more effective integration pieces, but nonetheless, that's what we feel there's a problem.
Quick question. So,
yes?
but don't they have lots of bad prior social experiences?
Yes. So, but they have very good prior social experiences as well. So the idea is that we all have both bad and good, right? And so maybe if what you're suggesting, Josh, is the balance is tipped a little bit more in favor of having bad social experiences in the past, I wouldn't argue against that. But I would say that what's happening is we do have people who will report, and also we have, clinical interview evidence of having positive social experience in the past, but they're having challenges in using that information and translating that information into current drive for goal state. This is mostly a theoretical model versus a kind of an empirical model, because a lot of what we know about this is really driven from general motivational properties. So a motivated state, broadly speaking, not necessarily specific to the social goal. So I'm kind of speculating that that's what's happening in the social goal. But what I was describing before, defeatist attitudes, things like that, psychological factors, why thrive only fail at a social interaction, I think a lot of that is driven by challenges in the past of not having positive experiences. Yeah. So what this may all lead to is that these kind of deficits in one's willful wanting of social connection could interfere with the ability to attain social relationships people would like. Okay, they want this, but they like this, but there's this challenge in translating this information into goal-directed behavior. So shifting gears a little bit, we do have evidence-based psychotherapies, behavioral treatments that work for people with psychosis, CBT for psychosis, supported education and employment, more directly targeting the occupational outcomes and domains, and then social skills training, which is something that works really well in terms of building those skills that will allow for and support meaningful social contact. So those work pretty well. But like any other psychological therapy, access is a problem, right? And so in particular for people with schizophrenia, we see poor access to these evidence-based interventions because of limited resources, financial resources, social support resources. It's also low motivation for treatment generally. And that is likely a product of avolition, but also could be a product of just having poor prior therapeutic experiences. And on the other side of the coin here, we can think about limited access as being a product of also not having practitioners who are adequately trained in these evidence-based practices. So I don't think I need to make this point very strongly to this group, but mobile technologies, smartphones, tablets could help scale these interventions as, I would say, as a supplement to existing care, not as a replacement. So social motivational problems, limited access, let's build an app. There's an app for that. There will be an app for that. So we developed the Motivation and Skill Support app. I'm coming out of the state of Massachusetts, so that's where the initialism comes from. This is funded by NIMH with an R21 mechanism. And this is in collaboration with David Gard, who's at San Francisco State, right down the road, and Kim Muser, who's my colleague over at BU. Whole idea of this is to develop and test the ecological momentary intervention to improve social connection in these folks with schizophrenia or schizoaffective disorder. It's a 2-site study, so we're actually actively recruiting here in the Bay Area. I wanted to make a plug while I was here. And in Boston, in the greater Boston area. So we finished our phase 1, which is this kind of usability testing mobile app development, which is what I'll be talking about today. We also have phase 2 ongoing. So I'll tell you a little bit about what we're doing there, just an open pilot trial. So in terms of phase 1, and feel free to interrupt if you have any thoughts or questions. Phase 1 has involved our expert panel, which is a group of consumers with schizophrenia and schizoaffective disorder. We've run focus groups. Also done some individual interviews with clinicians who work with folks with schizophrenia and schizoaffective disorder, asked them questions about the social needs of their clients, what they feel would be useful in an app to supplement existing care. Then we've had this long iterative process of app development. I'll talk about our social goal prototypes, which are really our library of social goals that people can work on through this app. The most fun but also frustrating part of this was the social skills training video filming, where I became a screenwriter for a few months and David Gard together, and we're not very good at that. And then the ecological momentary intervention logic and structure, so how the app actually looks. So I'll talk a little bit about that. And then we did usability testing in a small group of people, both here in San Francisco and in Boston. So that involved an initial goal selection, using the app for 2 weeks in this case, just to kind of get a sense of what the app was like and what it was like to try to work towards goals. And then I'm coming back and doing qualitative surveys and survey feedback, qualitative interviews and surveys. So in terms of the focus groups, these were fun. We did about four different focus groups, anywhere from only 2 to about 6 or 7 people. And I'm just going to pull out a couple quotes that I thought were interesting. So in this one, friends, while I wish I knew more normal people, I know very few right now these days. I have very few friends who are normal. And somebody followed that up with, that's the same with me. My contact with people is mostly in the mental health field. I have lots of relatives, but they don't contact me and I don't contact them. So one of the big themes of this is just pulling these examples out. A big thing for us was that people with schizophrenia do have relationships, but at least in terms of our focus group members, they felt those relationships were primarily with other people with schizophrenia or with mental health conditions, providers themselves. Often when you talk to people with schizophrenia using a standard social functioning interview, they'll list therapists or other treatment providers as their primary contacts and relationships. But this idea of normal people, what are normal people? In this person's mind, normal people were people who didn't have this condition, right? So they're saying, I want to connect with just broader community, not just people who I see in these settings, and also not just my relatives. And we found this with a lot of our mobile assessment work, that a lot of people with schizophrenia are listing close relatives as their primary contacts in their daily lives. And why do we need social connection? Well, I don't really need to make that case very strongly, but here's an example from a consumer, which is, I'll put it this way. I don't think I've ever been paranoid when I was with other people, which was surprising to hear that. So when I feel it coming on, I'll just go hang out with my friends and I'm fine. So it's like, we usually think if you're out in the social environment, that causes paranoia, right? Well, in this case, when they're alone, they're feeling very paranoid. And I think that makes sense clinically too. When people get isolated, it's really hard to kind of test some of your assumptions around what other people are doing. So I thought that was a really interesting quote too. So that's what we want to do. We want to connect these folks with other people so they can help manage not just their social functioning, but potentially other problems and symptoms they're going through. So other takeaways that we found from these focus groups were really that a lot of consumers were describing reminders of some sort. They even described wanting a sort of calendar of social events or opportunities to connect with other people in the social domain, just opportunities for social connection. So in an app, can something pull up and say, go here on Saturday and connect with other people. Here's an opportunity next Monday where you can meet with people that you might have shared interests with. We also talked about this, again, supporting face-to-face connection or contact with people that were other than their providers. So that was a big thing as well. And then came up a few different times was a strong desire for meeting romantic partners. So that was not something that we were really initially thinking a lot about. We said, maybe that's another social goal that we can list in our prototypes, but this was like really important for a lot of people. So we wanted to take that seriously. So these prototypes were basically, so I don't mention the data that I got from the providers, the expert clinicians, but essentially a lot of what they were saying was pretty consistent with the consumers. They did mention other aspects of an app that would be useful, but they did, I think the key takeaways from those interviews were build an app so that we as clinicians can really work with the consumers directly on whatever goal they'd like to work on. So it's not something that's kind of separate from the therapeutic process, which is really how we think about these apps.
Okay.
Yeah.
Is this for people across the course of illness?
So yeah, so our inclusion criteria are just adults.
Okay.
Yeah, and so we're not limited to first episode or multi-episode, and we've had mixes of both. And as you can imagine, there are different social needs and preferences across the development of this condition. So we've, in our usability testing, we did have a couple who were kind of more first episode or recent onset, a couple who were kind of middle age, and then a couple who were kind of on the older spectrum. So yeah, and it's hard to develop an app that's helpful for everyone, but what we'd like to do, and this is just our kind of initial setting, is like build something that is kind of a foundation for potentially moving forward to make more specific, for example, specific goals that people could really set themselves. And so an example goal, and this would be this kind of overarching goal, would be make a new friend by going to events you're interested in. And within that, we're building out the steps necessary. And for any of these goals, we have somewhere between 8 and 12 steps. Things that are achievable, maybe within a week or a couple weeks time. And they're listed them kind of hierarchically, but all of them are essentially attainable goals and work towards that end goal state. Other features of the app, we have self-monitoring of social goal progress. So this is just the EMA component of this app where people can report the progress they're making towards any of those given steps, and then progress to the overall overarching goal. The target really there is social motivation. So if we're able to structure goal setting and goal attainment in such a way, we anticipate that will help people feel motivated because they feel like those sub-goals are attainable versus saying, I need to have a girlfriend at the end of this. Oh my gosh, what do I do? That's a lot to think about. So this is very, piecemeal goals. The temporal experience pleasure model, that's built in here. I'd say this is more of our key target, which is that people can report on their past progress towards goal and also the affect they felt around interactions. And this might get to your question a little bit, Josh, just how it works in the app. I'll speak more specifically about that. And then the goal support, so not only monitoring your progress towards goals, but breaking it down in these hierarchical kind of clusters. So we could say these are more like easier goals you could accomplish pretty relatively quickly with not too much effort. Here's some that are a little bit more work, and then here's some that are a lot harder. And we structure those in the app so that, when I'm struggling and maybe I'm not really sure I want to go full bore right now, here's some other options. Here's some easier options.
Hey, Dan?
Yeah.
When talking to these people, were there any particular apps that they used kind of in concert with each other to try to basically kind of get at some of these things?
Yeah, I mean, so we did ask about that in the focus groups. We asked about social needs, and then we focused on what's your typical mobile, or technologies. And for the most part, and as you can imagine, this is very tied to age, right? So those who are younger, a couple of the younger folks in our focus groups had all your standard social media apps, at least, but not so much, health-related apps. So they were just kind of connecting with their friends and other relatives and things through Facebook and Instagram and those kinds of things. And when it came to those who were more middle-aged, and especially those who were older, they really often didn't have a smartphone at all. And so part of what we're doing with this intervention is we're providing smartphones. If they had a phone, it was a typical phone, kind of no app-based phone, not a smartphone. I want to call them a dumb phone, but yeah, phone. So they're using those to contact people, maybe text message, but certainly no apps, right?
Dating apps?
Yeah.
No dating apps among the folks that we talked to, and that was part of what we wanted. Nobody, yeah, and we wanted to actually introduce that as a potential way to connect with others through a dating app. But the kind of technology literacy overall, you know, was definitely not on par, I'd say, with your standard person at the same age group. And what I've noticed with schizophrenia in particular is it's like, when you talk about first episode population, like pretty much as you would expect, anybody in their early 20s, they're using their phones kind of in the same way, whether they have schizophrenia or not. But then when it's that older generation, you know, it was like my parents have Facebook, but my parents' age among people with schizophrenia, I see that digital divide, that disparity, where it's really kind of a generational plus clinical condition type thing. And there's some data suggesting that seems to be the case, like John Torres's work and surveys of people in mental health facilities, and kind of see that separation among those who are more, you know, severe mental illness later in life. We have encouragement through there, so there's kind of like these positive affirmations or a set of encouraging quotes, and David Gard really spearheaded this because he said, let's not do some stupid, like, you know, hang in there with the cat hanging from the branch, but like actual, you know, validation. We know this is hard to work towards your social goals, and these are challenges, but, you know, if you can take one step at a time, you can really make a lot of progress that's meaningful to people, like things like that. And we have a library of those, maybe something like 50 or so that randomly pop up, and I'll show you when they pop up. That's kind of the encouragement piece. So this is all targeting social motivation, and then there's the skill modeling piece, the social skills training videos.
Can I ask about the breaking the goal down
Yeah.
into steps? So do they need to report like a general goal for that? Like, I want to go on a dating app, and then you have pre-populated the steps involved in doing that, or can they make like be more esoteric?
Yeah. So for this phase 1 and 2 of this project, we developed the social goal prototypes. Mm-hmm. So the overarching goal is among those like 10 or so big goals. Yeah. And we work with them in the initial assessment to identify what's a particularly helpful goal for them. And then the subpopulated goal steps within that are also what we've established that are would help work. But that was a big challenge of this, was just what makes the cut? Yeah. What are the key goal prototypes and steps that go along with that? Yeah. And we wanted to get feedback on those too, and usability testing, like how did these work for you? And it turned out one of them, actually the dating app, didn't work very well.
Really?
So and so we in phase 2 we ended up removing that one because it was just problematic. For now, I can talk about a lot of why it didn't work, but it was one of the key things that was a problem. So we actually moved more towards, like, you could go on a dating website to kind of potentially meet somebody, but the primary goal was to meet somebody face to face. Like, so it was kind of like a way to move towards that, but always being kind of face to face as the primary goal. So but that is a challenge. I think ultimately, as I was kind of trying to say to Tim too, I think, but it was like in response to the idea of like who's the population first episode or later. Mm-hmm. Ultimately, we want to have kind of more idiosyncratic goal selection and steps and things like that. And it was more just trying to build into the app right now was a challenge, you know. But, hard to do that.
Is that where people use like co-chairs with these humans?
Yeah.
In real time.
Yeah.
That's a whole different kind of path. Right?
Tim was one of those coaches, right? For Daniel Schlosser's app. So the GIFs worked. So this is what our videos look like. This is the basic kind of front page of the app in an earlier iteration. I don't want to go into too much depth. I could talk for 5 hours about just this process, but it was making film scripts and identifying actors and a film crew and finding ways to get this on the app, and with no budget, and because the R21s are no money. So that was a lot of fun. But we did somehow find all of those things, and we made some videos. And there are 2 dyads, male, female in each. Gabriel and Maria is one dyad, and John and Sally are the other dyad. One is based in San Francisco, one is based in Boston. They are run through a narrative. Essentially, each of these dyads go through a narrative. One is to reconnect with an old friend, which is Gabriel and Maria. They see each other on the street. They, through a series of exchanges, rekindle their relationship, a friendship. And John and Sally was born on the end of a romantic relationship, so ability to form a relationship with somebody you know. They know each other. The story is they know each other from the recovery center. They meet at the recovery center. They move forward through that narrative until they're kind of like, hey, let's see a movie together, just me and you, kind of thing. The video library is something that's available on the app, which is broken into 4 chunks where it walks through all narratives, but just in larger chunks of information. Each narrative is 20 minutes total, so they're brief. But this gives the user an opportunity to view that video. We actually kind of give them homework, if you will, in the first week that they're with the app to watch the videos and get to know the stories. But then where this comes back is that while they're interacting with the app and they're going through their social goals, we have these broken down into specific social skills. Making eye contact, making a positive request, disclosing mental health needs, all these kinds of basic social skills, and they link up to our social goals and the sub-goals that are kind of where they're appropriate. So they can view those kind of prior to potentially working towards their social goals. Now, this is different than social skills training because social skills training involves a lot of back and forth and role plays and behavioral rehearsal and all these things. So this is like, I'd say very much SST light. It's just the real observation modeling piece of that. But we have the interactions and then we replay the interactions with my voiceover, my lab manager's voiceover, to walk through the steps of each of these social goals so that they can kind of see what are those individual components. It pauses, but it's really in big text, like this is eye contact and this is turn taking. And so that's kind of our evidence-based practice that we're trying to integrate into this. Now, you don't have to see what that is, but essentially this is just the logic structure of the EMI piece, which is that kind of back and forth going through the questionnaires. And that gets into essentially what this is, which is just a kind of example. It's not what the app actually looks like now, but this is what it did look like in earlier iterations. How much progress can you make towards the following step? Identify an event that interests you. So this is where it would happen. We made at least a little bit of progress. So no progress, we don't move forward, at least a little bit of progress and or at least a little bit of happiness around that progress. Then what happens is when we're moving towards our goals in the future, we identify an opportunity where motivation to seek out contact and or confidence or attitudes around that contact is low. We feed back the information about prior experiences when this progress was at least a little bit and the affect was at least a little bit positive. So that's that temporal experience of pleasure model piece. We're trying to build that back into opportunities for intervention in the moment. Josh, it's very possible that for several weeks they didn't have any of those, and essentially this piece would not be integrated in that particular moment because we don't have data from their own experiences to then feed back to them. That hasn't been the case so far in our small samples, but it's possible that they don't make a lot of progress or they don't feel good about interacting with others. They haven't had those previous positive experiences. So that's where two possibilities, either that they felt good about a prior positive social experience or they made a little bit of social progress. So in either case, we tried to build back the affect around that.
In my clinical experience, it's hardly ever that they have no joy at all,
yeah,
make no progress. So that makes sense.
Yeah, yeah.
I guess I was asking about like over their lives, they probably had a lot of rejection.
Sure. Yeah, absolutely.
But not 100%.
Yeah, yeah. That would be very black and white thinking.
Yes.
No, I totally know what you mean. Yeah, I agree. Yeah, because so that will set them up in their history with being less likely to be able to drum up positive experiences if it's just the case that those haven't been as much there. Yeah.
So it seems also, one other question, it seems like you're trying to help them remember when things felt kind of good, because that's a particular deficit. Remembering good things is hard for people's experience.
Yes. Yeah. And we think particularly in the social domain, because I think that's maybe because of all of that long history of challenging experiences, maybe the most immediate thing that pops up is, are the ones that are most salient, right? Those that were bigger struggles or more challenging. So maybe if we can build in more recent positive experiences, assuming that those are happening, then that could maybe override, the default, which is to say that why reach out to others, it's always going to be a failure and not be fun. Yeah.
Do you have any content that addresses alcohol use or just the presence of alcohol or other substances in social situations?
No, but we rule out. It's part of it's like our only exclusion criteria, which is substance use disorder meeting criteria within the last 6 months.
But still, I have a similar question because especially right now, there was a new Lancet article on cannabis use and psychosis, and they always assume like this causality, which is not necessarily true because it can be self-medication also. So it's totally possible that many of these people are maybe not in your sample, but otherwise benefit from substance use to actually facilitate social situations and connections. And not only like legal substance, but also medication. It would be just very interesting to know in how much the substances have helped them to actually progress in that process.
Absolutely. We actually, I've always had this hunch that I feel like I've seen in a few larger studies this interesting positive correlation between substance use and social functioning in severe mental illness. I don't know if it carries across in other conditions, but it makes sense to me for the exact reason you're describing there. It's like, well, if I'm using substances, often it's in the presence of other people who use substances with me, and therefore my social functioning score will be higher because I'm with other people. But also, you can't ignore the fact that eliminating substance use could potentially also eliminate your social support and that the people around you. So you have to clearly replace it with positive social experiences. But it's a great point. But we really had that exclusion criteria mostly because we envisioned that it would be a challenge to really actively integrate with the app, and in our usability testing, I'll just fly through this real quick. We did some clinical measures. We did 3 surveys a day for 2 weeks. These are just our people that were in the usability testing. These are the goals that we identified with them that would be relevant for them. These are the survey adherence. We had pretty low adherence for a couple of people, but ranging up to basically everyone filling out every survey, so everything in between. Video adherence is just those 4 video clips that they initially watched through that first week, and everybody but one person watched all 4 videos. One note that I'll just pull out there is that this person who identified a romantic relationship to build out with somebody you already know, that's the goal we did away with, because we realized that it was a challenge to really start with a relationship that already existed and then move it into a romantic domain. That's like a pretty it was a desire among our participants that they wanted that to happen. But the challenge inherent in making that happen, given we don't know the history there, we don't know if it's appropriate for them to do that, that's why we removed that goal.
It's a pretty high level,
going to the next step. That's a tough one.
Getting out of the friend zone.
Getting out of the friend zone, exactly. That person also, people talk about this all the time. I didn't mention that we also do a lot of social sensing stuff. So we gather GPS data, sometimes microphone, accelerometer through the cell phone. And in this particular project, we do GPS because it gives us a sense of where they're spending their time. And that's another outcome for us. In the consenting, very clear, we talk about that. We talk about that it's not real time. This gentleman identified that they were fine with that and consented to the process, but then we found out later disabled the GPS afterwards. So I said, I don't want you to know where I was.
For their GPS data, is that something that patients are able to get reflected to them in the app, or is it just?
No, it's really just part of our outcomes data essentially. But I do think that moving forward, that'll be a really Jasmine, who's a postdoc in my lab, is trying to look at connections between physical activity and social activity, because we have a lot of sense that when people are isolated, they're clearly not physically active, and have connections among those things. So I think for a future iteration, we definitely want to do that.
Video adherence is like watching the videos.
Just watching the videos, this is not the ones that pop up within the app, but initially the 4 chunks of the narratives to kind of see, did they get the story, basically. So I won't go into too much of this, but just we got a lot of feedback and qualitative interviews afterwards, and some of that was like, stop asking me to fill out surveys. Like we do a lot of EMA data, you know, but typically our EMA studies are no more than 1 to 3 weeks tops, and this is an 8-week intervention that we're ultimately going to do. And it's an intervention, and this is kind of a new space for me. I'm mostly in the assessment space, so we're like, yeah, you know, 5 to 10 times a day EMA, everyone's, you know, no problem with that. Here, they're like, no, thank you. So we moved to 2 a day, and that it kind of worked out well because we have one semi-randomous notification in the morning time, so they could potentially work towards those goals throughout the day, and then one later in the evening time, so for those who kind of work more towards evening-related social goals, that supported them. And they time out, so you know, after a period of time, they're not there anymore. So we moved that, just made a few other changes here. And then here we are right now. This is where I'll wrap up. We're doing our open pilot. We gather clinical measures at baseline. We do this goal setting piece, which is, I haven't talked a lot about that, but that's a fun piece of where we have this kind of structured way to talk about what your social needs are, how can we help you with those, how does it fit with our prototypes. The 60-day intervention period, we check in by phone initially, then once a week after that, do the clinical measures at termination after that 60 days, and then 90 days following that termination, we do clinical assessments again. And I mentioned before that we provide a smartphone for them to use. We provide the data plans. I wish we could give them data plans forever, but we can't, and that's part of the problem in this population is there's lack of resource and access. But we're brainstorming, trying to think about how to provide information for these folks who don't have smartphones already or can't afford a data plan, which is actually pretty common, how they can find affordable plans using this phone that they'll now have.
What kind of phone do you give them?
It's a Samsung. This is all Android based, so S8 I think is the one we have. It's a pretty nice new phone. It's an agreement through BU where they basically provide the phones for free to all of our research participants, and we just pay $50 a month or so for the data plans. It's a bit of a headache because it's a clinical trial. We're bringing people in. We don't know when we can turn the data plan on and off and all these kinds of tricky things, but it's nice to have that. Those are expensive phones. And I mentioned the no active substance use disorder exclusion criterion, particular interest in improving social life, often the case, so trouble finding those folks, 18 to 65. So if you know anybody, please let us know. And this is David Gard's lab over at SF State. So if anyone you might know can get to San Francisco State that has a diagnosis of schizophrenia or schizoaffective disorder, please let us know and provide more information there.
Have you lost any phones?
We haven't. Well,
They give them.
we give them them, but yeah, they
keep them forever.
Forever.
So you've lost all the phones.
We've lost them all, and we'll keep losing them indefinitely. But they haven't lost the phones as far as we know because we're gathering, the data is continuing to be gathered unless somebody else is gathering.
That's part of how
data
you
for us.
pay them.
Yeah, that's the compensation base.
That is the compensation.
Well, not the only compensation.
What
So
about they have a phone already?
then they have to have 2 phones, and that's something that we've talked with them about at usability testing. That a couple of the younger folks, like, do I have to carry another phone for the purposes of the study? Yes.
So they cannot download this on their own?
No, we decided to keep everything standard, especially with we partner with Ethica, which is a company out of Canada. I don't know, I'm sure that if we use their phone, this would work out okay. I'm like 90% sure, but we don't know 100%, and there's a lot of variability in the phones, so we're just like, let's keep those standard for the purposes of this assessment. But moving forward, and that's the idea, is that if anybody can use it on their phone.
We run into problems or challenges with this stuff. If they use their own phone, but they're using their plan,
Yes.
how do you reimburse them, or do you reimburse them? Are they now paying to participate in your study?
Yes, exactly. That's a really important point, especially things like GPS, which are very resource, hungry. You could be sapping their data and battery life and all those kinds of things. So we just keep that constant.
How is it? Do you have a list with links to events or whatever happens there? And could you maybe in the future even think of linking specific events to specific interests for the people? Because there's so much on mindfulness, sound healing, whatever.
For
It
sure.
can help you people to connect with others and experience.
That's what they told us too in the focus groups. That's what they want, right?
Yeah.
Which makes sense. Like this kind of calendar, if you will, like things are popping up and they're able to connect them with their actual interests. And that's what I'd love to be able to do, moving forward. So, yeah.
On the calendar, you can also put all the other research studies they can participate.
Yes, exactly.
Right.
Right.
To do that.
Exactly.
Dan, how did you decide to apply for an R21 instead of an what is it, 56? The development.
Or 33, 61, or
No, the development one.
34.
R34.
oh, R34.
Yeah.
I actually think that we might do an R34 next.
Yeah.
Or an R33. There's the R61, 33.
Yeah.
It depends, what we find.
Yeah.
The 34 is better for just if we want to do an RCT essentially, and this is an
Yeah.
open pilot. But this was actually an RFA for forgot it was AdopTech, and it was some acronym that was like optimizing technology for social functioning across mental illness. And so I
That
think,
makes sense.
yeah. Well, David Gard and I had been doing a lot of EMA stuff, and we were thinking about writing an R21 and like looking at social motivation from an assessment standpoint. And then this popped up, and it was due in a month. Like,
Of course.
okay, how about intervention work?
Yeah.
But all of the assessment work I've done is always in the interest of trying to develop better intervention. So it's like, well, go ahead and do an intervention, and it's needed I needed the motivation to
Yeah.
write an intervention grant.
Yeah.
And NIMHs right now, it's all about some sort of target mechanism. And so in our case, we have all these EMA reports of social motivation, and that's really, for me, that's the mechanism, right? So if we can target social motivation, get people more interested in connection, and if we get signal on that, that's really what's important for the next step. Like you say, that's why people potentially would get better in social functioning.
Very cool.
And social functioning doesn't, Kim User's a co-author that he's like, we're not changing social functioning. It's not going to happen.
Mm-hmm.
He wrote the manual on social skills training, but I think he thinks because it just takes a longer period of time, and we just don't have the time to really see a big change in that. But we have a 90-day follow-up, so that's 5 months from the beginning of the study till the end, and I think we could maybe see something. I'm more optimistic.
Yeah.
So,
Great.
yeah.
Good.
Thank you.
Oh, that's awesome. Thank you.
Let's see.
Yeah.